Amar, it's been a busy week for us at Value Health Voices. This is our second episode in a week. But more importantly, it's a busy week for the entire House of Medicine because it's July, and with July means the Medicare Physician Fee Schedule and the Hospital Outpatient Prospective Payment System proposed rules have been released. And so we got together with two great guests tonight to comment on all the implications.
Right, Anthony. And compared to some of our past episodes, we're really going to delve deep into the world of radiation oncology today and how these payment proposed rules will impact the radiation oncology specialty. And so our guests are the presidents of two of the largest radiation oncology societies in the United States. So we're very excited to have them on.
Yes. And we are, as we've said many times on this show before, oncologists and radiation oncologists. And we thought we can do two things with this episode tonight. We can, of course, delve into, as you say, details related to our field, but also it's instructive about the dynamics of the entire House of Medicine, specialist care, and how specialists are paid versus primary care, for example. So we're very excited. We have with us Brian Lally, Dr. Brian Lally, who is radiation oncologist in South Carolina, and he is the current president of the American College of Radiation Oncology, ACRO. And alongside him, we have Dr. Samir Keole, who is a radiation oncologist in Arizona, and he is president of the American Society for Radiation Oncology, ASTRO. So welcome to both of you gentlemen.
Hey, thanks for having us. I'm excited to be here.
Yeah, looking forward to this.
My name's Brian Lally. I'm a radiation oncologist at an academic center in South Carolina. I also am currently the president of the American College of Radiation Oncology. However, the views that we're going to be discussing tonight represent my personal views based on my experience and how I practice in my clinics.
My name is Samir Keole. I'm a radiation oncologist in Arizona, and I am the president of ASTRO, but the views that I will express today are mine and mine alone and do not represent either my employer or the society.
But you guys have reminded us, Amar and I often forget to do this, but the same also applies for us. Neither one of us is the president of anything, but the same thing goes that our opinions here are our own and not those of, I don't know, the United States of America or my employer here in Ohio where I live.
Well, I wanted to start off and I think just really go up 10,000 feet here for a lot of our listeners and viewers who are like, what do you mean by this proposed rules? What are you even talking about? So I thought we can kind of just level set and just talk a little bit about what this means.
I want to tell everyone in the audience that right now, you're going to be explaining something that's really critical and they need to listen because this stuff really impacts how the clinic functions. You may not believe it, but the stuff you're going to hear tonight has big implications for how we practice and what we do. And it's important to be very knowledgeable of these subjects because it will help you a lot down the road when you're up to my age.
Very true, Dr. Lally. And I think the other important thing is a lot of this is going to be talk about reimbursement, but that is not the bottom line here. A lot of what we're talking about impacts all other kind of services toward patients, wraparound services that hospitals use to support patients, such as social work, nutrition, nurse navigation, access to patient care, keeping centers open in rural areas. So all this reimbursement is what allows hospitals and clinics to operate and provide the services that our patients need. So I think that's really important. I don't know, Samir, you have anything to say about that?
No, I think that, this has been... This is, I'm sure you're going to get into this, but the fee schedule, as we're about to get into, was implemented in 1992. Medicare, as everyone knows, that was implemented in 1965 and had runaway costs for, that was recognized for about 20 years. And then it was in the mid 80s that it was recognized we had to get away from customary prevailing and reasonable charges, or CPR. And that led to the Harvard study by Dr. Tsao that then led to the 1986 COBRA legislation signed by Reagan and 1989 OBRA signed by Bush 41, which led to the creation of the system we're in. And when I'm on something like this, I always want to give credit to Dr. Bob Bogardus, who passed away in 2018 or 2019 and got the gold medal in 2015. When we decided to switch, where it was decided that we would switch from customary prevailing and reasonable charges to a resource-based relative value system, RVRVS, and Anthony and Amar are experts in this and will walk us through this. Bob Bogardus, along with plenty others, Michael Steinberg gets credit, a lot of other folks, he knew what this meant. He somehow, the light bulb went on, it clicked, he got it, and he started creating process of care. He created 77427, the weekly management code, and other codes, many of which live today. So we always owe a debt to Bob Bogardus. And then we've had a whole slew of folks from both ACRO and ASTRO over the past, 33 years that have really carried the torch for us, and including our current RUC advisor, Amar Rewari. I think it's important to give history that system has been around that we're in right now. This is the 34th year of it.
I think that's incredibly important background because, as you mentioned, this concept of Harvard value, that just means that when procedures used to be valued, when Medicare first came about and they were trying to figure out how to create this kind of valuation in the early 90s, they just looked at valuations that had existed in this Harvard valued registry, but it wasn't based on anything. And then over time, the AMA, the American Medical Association, decided to create two committees, a CPT committee, which is the committee that creates our procedural codes in the House of Medicine, and a RUC committee, which is the Relative Value Update Committee, which is the committee that values all our codes and sets these relative value units, which is how we get paid, the RVUs. And then, so those codes are created at the AMA. They own all the procedural codes, and then they send it to CMS to get valued. And CMS, the Center for Medicare Services, creates valuations for those codes. And every year in July, they drop this proposed rule, which is their proposal for what all those codes, both on the physician side and the hospital side, should be valued at and reimbursed at. And they have this comment period for a couple months after that, where they allow all the other stakeholders, whether it's industry, whether it's providers, whether it's hospitals, professional societies such as yours, to all submit comments about whether they want any edits to that proposed rule. And then the final rule comes out in November of that year, which starts the new payments for those procedures January 1st of the following year. So right now, this proposed rule that came out this week is for new payments, potential new payments that would go into effect starting January 1st.
And I mentioned it right off the top, there are two separate sets of proposed rules that come out. There is the Medicare Physician Fee Schedule, which it's right there in the name. This has to do with the fee schedule for professional services being the term that's applied to physician work and the associated professional billing there. And then the hospital outpatient prospective payment system is not a representation or a payment system directly for physician work, but it is instead a payment system specifically for hospital outpatient services, so facility-related payments.
Yep. And so I think what's really important to understand about some of these topics is when you have physician work. So as doctors, we do things, right? As radiation oncologists, we radiate people's cancers. If you're a surgeon, you'll operate on somebody. Those procedures that the physician does have a value to it. That's called your work RVU. And that is calculated based on your time you take to do that procedure and how intense that work is. And so those go into it. And the way they calculate that is surveys are sent to all members of professional societies who perform that procedure. And then they give feedback about the potential time and intensity relative to other procedures in the House of Medicine or relative to other things they do. And that then goes toward that valuation for physician work.
And Samir, you spoke about the history of the current system that we have, where we exited the previous system, which you detailed, and entered into this RVU-based system where the AMA has this responsibility, both in terms of the CPT committee and the RUC committee. There's a critical element of this that we're going to get into, the budget neutrality and conversion factor elements of this.
the R stands for relative. And so it's supposed to compare between specialties. So if the four of us were in four different things, anywhere from rheumatology to endocrinology to a gynecologic surgery field, that RVU is supposed to be equalized amongst all of us. And it's also, you should be able to look back in time. And so you multiply that, the number of RVUs you get for a procedure. So let's say I do procedure X, I'm changing a widget, and I get 10 RVUs for that widget exchange. You multiply it something times the conversion factor, the CF. And we wait with bated breath on what the CF is going to be. And so the conversion factor is a dollar amount. And so in 1992, when this system first came out, the conversion factor was $31. All of us on here know, but for the casual listener, you may not realize that today in 2025, the conversion factor is $32.36, a little bit less actually. So it's gone up $1.36 over 34 years. The inflation rate would say $31.92 is roughly $70 today. So we've lost, in terms of buying power, so to speak, more than 50%. And certainly we've seen costs go up astronomically. So I think it's just worth, even before and a lot of that has to do with budget neutrality, the fact that you can only, for radiation oncologists, we're trying to make this general, but for radiation oncologists, frequency times wavelength equals the speed of light. So if you're going to drive up one, the other goes down. That's just the way it works. We have a pool of codes, and as you add more, then by definition, the CF has to go down, because they only allow, I believe it's up to 20 million per year in a rise without some intervention. The fact that budget neutrality is the game that we have to play in, I think that's why a lot of folks don't understand why do we go up every year? Well, because we're competing against everybody.
That's right. No, I set it up for you to get into those two things. Brian, go ahead.
Yeah, but it's a bigger picture than that to me, because I think we have expensive toys in our clinic. And as I'll get into a little bit later, I'm doing things in my clinic that we didn't do back in the 80s. The toys are expensive. Their maintenance is expensive. The software that we use is expensive, and you get all these different packages for different things. I'm doing a lot of, reirradiation that we never used to do, and treating a lot of things we never treated before. So the complexity is going up, and you need more staff to be doing stuff. So the costs are just expanding. What I get frustrated when I hear these discussions with Samir is the impact on patients is really missing in some of these budget neutrality discussions. In my practice, I have a large underserved population that I have to provide care for. And, we really need to make sure that everyone is getting the best care possible. Everyone's a VIP, because that's part of our mission. And that just doesn't fit into these budget neutrality things, which I get why they're there, but it's also frustrating at the same time. And I think the next generation has to understand the system Samir described is very complex. And the next generation really has to understand how complex of a system this is, and how all these factors are controlling your reimbursement. And if you have no good reimbursement, you have no mission to care for your patient.
Yes. Brian, Amar, excuse me. Brian mentioned something very important that you and I have talked about on this podcast before. He spoke first about the expensive equipment, but then started to talk about the expensive people, right? The roles in a radiation oncology clinic that are not physicians. And we spoke about the clinical labor pricing update in previous episodes and how that had a large impact. It was one of the mechanisms pursuant to budget neutrality that we used to direct more funding to clinics like primary care, where the clinical labor is predominantly nurses, away from other more expensive than nurses types of roles, such as physicists that we have.
Exactly, Anthony. And I think I'm going to just even step back again, just because it's just so everyone understands what conversion factor means. So we talked about, you have the physician work element. That's one part of an RVU. Then you have a practice expense element, which everyone's alluding to, which is the high cost equipment that Dr. Lally is mentioning, and also the staffing that you're mentioning, whether it's physicists or dosimetrists and radiation oncologists in radiation oncology, or nurses and other staff in some of the other specialties. All those all get summed together, and then you adjust for what geography you're practicing in. If you're practicing down south, costs are very different than if you're practicing the Northeast or California. So those get adjusted, and then they get multiplied by that conversion factor. The conversion factor is a conversion factor to convert a relative unit into a dollar amount. So that's how you get your actual reimbursement payment. And so, yeah, what's CMS and Dr. Oz now, what their mission has been is to redistribute payment from specialty care, proceduralists, more toward primary care. And it's a fixed pot. And so you have everyone jockeying for an amount of money that's not growing because you need Congress to approve growth in the total pot. And so everyone's jockeying to try to get a bigger portion of that. But they're instituting all these mechanisms to redistribute that toward primary care away from proceduralists through this concept of changing clinical labor pricing, budget neutrality, and the conversion factor, and changes in practice expense that we're going to talk about on this podcast.
Yes, and we're going to dive deep into the newest method. It's not exactly new, but it's new in its application in such a widespread way, and that's the so-called efficiency factor, which we'll detail as part of this conversation.
Just to drive that point home, as you so eloquently said, so over about roughly the past 20 years, if you look at the changes, the cumulative impact of changes in RVUs over the past 20 years, family practice has gone up 38%, internal medicine about 25%, endocrinology 24%. But what has not done as well, and this is because of budget neutrality, and this is why I don't like budget neutrality, because I don't want to be pitted against my colleagues in other fields. And that's essentially what budget neutrality does. But it's really hurt specialties with high-priced equipment and supplies. So radiation oncology is down 21%. And you might, the radiation oncology listener might be like, oh my goodness, man, what are these societies doing? Are they totally ineffective? Well, believe it or not, we've actually done relatively well, because vascular surgery is down 31%. During this time period, interventional radiology, 37%, diagnostic, 38%. So this is not to say, by the way, their societies are ineffective, because they're incredibly effective. Like the ACR is really a force of nature. And by the way, a plug for the ACR. I actually am a member of not just ASTRO as well as ACRO, but also ACR and ASCO, because I believe in organized medicine, and I'm a member of the AMA.
The American College of Radiology for our listeners.
Yes, American College of Radiology, who have been very good to us. That's where our roots come from. But I think those numbers should hopefully wake people up and say, oh my goodness, this is like when you're doing just professional procedures, codes, you're really doing well, but the technical component has really been hurt. And this is why our freestanding centers are hurting. This is why we're having consolidation. And we're seeing this, especially over the last 10 years. And this is something, I think we're all deeply, deeply concerned about. Certainly as president of ASTRO, this is probably my number one concern is, how do we protect the freestanding market? And it's just really hard to do, because anything with high-priced equipment or high-priced supplies is really disadvantaged in the current system.
Part of our mission as presidents of these societies is to increase the quality of care across the whole country. And to do that, you need resources, and making sure that mandate is in, because, as Samir said, those freestanding centers are getting hammered because of some of these reductions. And I think that's really important, that they somehow find some. It almost happened a couple years ago.
In 2015, we were looking at a 20% cut, and that led to PAMPA, which then kicked off a whole series of events downstream. But it was something we really had to get done for the field, because the freestanding centers were going to take a 20% cut overnight. So we lobbied like crazy, and we're able to get that into effect, which again has some downstream effects. We had to do that simply because the patient was on the table and losing blood, and we just had to put the tourniquet on. And so we did it.
What you say is absolutely true. And we've talked about it on this podcast in other contexts. We had Eric Bricker on this podcast, who has done work describing how the reimbursement levels for various services have produced the non-existence of services in huge geographic areas. These price that are below the cost of delivering the service, which by definition will produce the absence of the service. Very important, and we've hit on that. And as it relates to freestanding, so-called non-facility versus facility, procedural-based specialties, Medicare in this proposed rule is beginning to take some steps to realign that. The question is getting it right, as the devil's in the details.
Now I'm going to dive deep. And this is really, a lot of this may be specific to radiation oncologists, but I think it's important, since we have the society presidents on, to hear their perspective on this. So in this rule, there are new codes for treatment delivery and image guidance and surface radiation therapy, which we'll talk about a little later. But how they came to be, I think, is very important to understand. So as Samir mentioned, yes, I am a RUC advisor for ASTRO, but I also worked together with ACRO on creating these codes as part of our code development and valuation team that we formed between ASTRO and ACRO. And we were tasked with creating these codes, not because it's something we wanted to do. It's something we were asked to do by AMA and the RUC. These codes had not been revalued. Our G codes and our current existing treatment delivery codes for about a decade, because of stuff Samir mentioned with PAMPA and the ROAPM and all these other things that kind of kicked the can down the road. But ultimately, we had to create new codes to accurately describe the work we currently do as radiation oncologists. Radiation oncologists now, and Brian, you know this, it doesn't matter what energy we're using, 6x photons versus 15x photons. Why should the payment differential be different? These are outdated concepts. So we created 3 new delivery codes, a level 1, a level 2, and a level 3. And a level 1 is pretty much like the most basic thing. So it's for electron therapy and for 2D therapy. Then you have a level 2, which is pretty much your bread and butter code, which is what we did is we took 3D, but also combined it with IMRT. And then level 3 is kind of a much more complex code. And the reason, when we looked at how we were going to create these codes, we were like, do we create codes based on sites we're doing? Like radiologists have codes for different sites if they're doing an X-ray of one body part versus another. We look at how many sites we treat. Do we look at this concept of isocenters? And after a lot of thoughtful discussion between the two societies, we agreed on this concept of using isocenters and taking out the technology of 3D and IMRT. So level 2 is for anybody with a single isocenter you're treating, whether you're doing 3D or IMRT, doesn't matter. And then level 3 is for anything that takes a lot more time, because things that take more time, both for our staff who are giving the radiation and for physicists who may be coming in to observe, it should be paid higher. So that got moved to a level 3, which is anything we're doing with multiple isocenters, whether it's 3D or IMRT, doesn't matter. Or if we're treating things like total skin electron therapy, or if we're doing something with active motion management, where you're actually looking in real time at organs or targets moving, either through breathing or through surface guidance, because that takes time to observe. So that all got pushed to level 3. So I did want to kind of just lay that out there.
When you were arguing this stuff, explain to everyone out there listening, explain to the audience that's listening here, the level of knowledge of the people who you were trying to explain these codes to.
Yeah, that's a great point, Brian. And so I will say, so we have, like we had talked about,
Why is Samir laughing at me when I asked that one?
No,
That's a good question.
There's the CPT committee, which are CPT advisors from ASTRO and ACRO, Kate and Tarita representing us, and then the RUC advisors, which was me and Chris Jarvis. And when we talk to these people, they're not radiation oncologists. They're not radiation oncologists who sit on the committee. So you have to explain things that are very complicated concepts in radiation oncology to people who don't understand our field, which is why sometimes it's hard to get them to understand the valuation. And as we will see in this rule, it was probably confusing for CMS and others to understand maybe some of the nuances between 3D and IMRT that are the building blocks for these codes, which is why they got assigned payments not associated with the correct building blocks.
Yes. And we should say that this process this yearly process of a proposed rule being released. Then there is a 60-day period for stakeholders to comment and correct CMS's errors and potentially convince them of going down a different path. Only later then in November is the rule finalized. And so that's really the task now. And what Amar is speaking about specifically, and we alluded to it earlier, is that in the process that the RUC follows, they have to estimate physician work. They have to estimate practice expense, and they do that through survey methods. What CMS made very clear in this proposed rule is that they believe that that is an outdated approach or an ineffective approach for certain specialties. And as we, together with CMS, agreed on these new 3 treatment delivery codes, not the physician work, but the expense component of it is being arrived at through something called an ambulatory payment classification. And so we need to, in order to explain where we stand with this proposed rule, we need to go into that.
It may be useful for the casual reader listener to know that, number one, we never go and ask for revaluation of codes, ever. So this is why sometimes as the code sets grow and grow, I use the analogy of, imagine you have a 2-bedroom, 1-bath house built in the 50s, and now you built onto it and build onto it, and it's now 10,000 square feet with a bunch of bedrooms and a bunch of bathrooms, and then you've got to go to get into from the kitchen to get into the dining room, you may have to go through someone's bedroom. It doesn't make sense, but we don't ever reconstruct. We don't actually ask for revaluations until we're really asked to do it. And that's because it's tough to maintain valuations as you go back through the process. This is kind of a rule of thumb. So when we started, MRT, I believe, was first a code in 2003. So prior to that, there was nothing. So it went from 0 to being a $1.1 billion code, the number 4 code in all of Medicare by the year 2011. And that obviously got on the radar, and that prompted the last big code set revaluation, which I believe was like 2014 going into effect 2015 or 2016. So it was IMRT was billed under a number called 77418. And then as a result of us restructuring the code set at that time, and I was very involved in that one, we split it into simple and complex, 77385 and 386, but we needed to fix some stuff after the fact. And so these G codes got created. So as probably realized, for about 10 years, we've been billing one set of codes in the freestanding or non-facility setting and a different set of codes in the hospital or facility setting. And internally, we called it, so G codes are only supposed to be around for a few years, but we knew it was coming up. And in fact, it was due largely to Amar's work as well as our advisor that we did probably extend it maybe longer than it's intended, but we called this the G code cliff. And we knew at some point in time we were going to have to get revalued. And that just happened. Amar was called to the table along with Tricia and a few other folks, I believe in September 2023, and kind of instructed that they wanted us to take another look at this. Really, the take-home point is we never voluntarily go and ask for a revaluation of codes.
No, that's helpful context. And as it relates to our revaluation of codes and reassortment, as Amar detailed into these 3 treatment delivery codes, a key component of that is the practice expense component, which, as we spoke previously about the traditional way that is done and how CMS takes the advice of the RUC to arrive at what they pay for that. But it's important to state that in the Medicare hospital outpatient environment, hospital reimbursement, so now not talking about anything to do with professional services, but technical or facility reimbursement, is based on this concept of ambulatory payment classification, or otherwise known as APCs. And what CMS does is they assign, we mentioned earlier, the common procedural technical codes, the CPT codes. CMS assigns a basket of similar CPT codes to a given APC based on clinical and resource use similarity. And that is how the payment to the hospital is derived. So they are, in all services in a given APC are reimbursed at the same rate. And the process for this basically involves cost data that are collected from hospitals, including from their charge masters. And then in this HOPS rule, which was just released, there's a conversion factor also there that's used to turn that into what CMS pays in terms of a dollar amount for a given APC. And so critical in our new codes, and Amar made reference to this, is that each of our new codes is assigned a given APC for the technical reimbursement of that. And so what we're going to do now is talk about what's been done in the proposed rule with regard to APCs, and likely what at least we hope would come out of this period, this 60-day comment period, in terms of dialing those APCs in to the right level to make sure that we don't have cuts that were not even necessarily CMS's intent, but potentially just a knowledge gap more than anything else.
Yeah, no, exactly. And I think one of the things to realize is this is actually a good thing, what they're thinking of doing. It's thinking outside the box. It's what we've been advocating through both these professional societies for years, which is payment stability, right? We know that radiation oncology, as Smears pointed out, has had these huge cuts, 20-something% over the last decade on the Medicare Physician Fee Schedule. But on the hospital side, it's been relatively stable. And the reason for that is this cost to charge data that the hospitals provide. It's a more stable form of payment. So CMS is looking to figure out ways to stabilize payments for us because they understand that it's not sustainable to have these huge cuts in radiation oncology. They're also worried that the data that goes into what people submit in surveys can be flawed, right? You may only have 3 to 5 surveys submitted on data. You have to submit invoices for these high cost equipment to get priced through the RUC process. A lot of people have non-disclosure agreements. They don't feel comfortable sharing that kind of information. Their institutions don't let them. And so they have very limited data to calculate this practice expense. So this allows for a site neutral kind of payment methodology with payment stability. So the intent, I think personally, speaking as myself, is a good thing. It's just the execution that kind of failed on this one. And that is because the building blocks they used to build the codes were incorrect. They deleted, as we knew they would, the 2 IMRT codes because the IMRT services were bundled into the level 2 and level 3, the new level 2 and level 3 treatment delivery codes. But the numbers of those codes are the same numbers as was already used in our legacy 3D codes. So when they deleted the IMRT codes, I'm not sure speculatively that they understood that IMRT was now being bundled into those new codes, so that our level 2 had IMRT in it and our level 3 had IMRT in it. So when they assigned payment, they looked at the hospital outpatient payment, the APC, for 3D radiation therapy, which is a level 2 payment. 5622 is the number. And they assigned both our new level 2 and level 3 codes to that payment because they thought it was 3D only. I'm speculating. And so what we want them to do is to reassign those valuations to IMRT and the IMRT plus. So instead of assigning it to a level 2 level, we would like them to assign it to a level 3 and a level 4, which more accurately accounts for those bundling services. They have these Excel spreadsheets they put out there for the public that shows all the cost data about what goes into all these codes. And when you summate and look at the geometric mean, they call it, of the costs for IMRT and the cost for 3D, you can see that it's drastically undervalued, the new valuations they did. And so we're hoping that the whole radiation oncology field, ACRO, ASTRO, everybody gets together and advocates CMS to correct these linkages to the APC payments.
Well said. I think we call this crosswalking, and we think that the crosswalk was done incorrectly. Within 24 hours after a lot of us had looked at this, we said, sure looks like this crosswalk's wrong. But again, we're going to have to do some work here.
You're not going to find anybody in the radiation oncology stakeholder community on the other side here. It's just a question of kind of getting the word out, making sure people understand this, and making sure that CMS hears it from a plurality of radiation oncology stakeholders to get this sorted out.
Yeah. And not just radiation oncologists, because this, like I said in the beginning of the podcast, impacts the The money that flows through radiation oncology programs in the hospital setting impacts all those other services that we talked about. And so the hospitals have an incentive here. And so I think this should be something that the American Hospital Association, some of these other large professional societies also need to understand the ramifications of this for their cancer programs and access to patient care. And they should be advocating also for changes in this to CMS.
Yeah, that's a great point. I see that in our all the things that we are charged that are charged to us for other services. I'm talking about my department, and it's because the revenue is generated and it goes to cover those areas that are not that are important services for our patients that unfortunately don't generate enough sustainable revenue on their own.
Brian, do you have anything to add to that?
No, I mean, I'm in 100% in agreement with you guys. I mean, I think the main thing is that the word of this and how there was what appears to be some type of misconstruction, if I can call it, needs to be explained to our membership of both societies. And then we need to ask them to try and make sure that they, we have those little grassroots sites so that people can let their congressmen and other people know, and that we mobilize our voices to explain how this is really going to impact patient care in the wrong way. And you mentioned the AHA, but it's also our therapists, our dosimetrists, our physicists, and nurse societies. This is, we tried as a society, we have been one of the best at policing ourselves. As a profession, we have been one of the best at policing ourselves, moving towards hypofractionation, doing studies, trying to find ways to do cost-effective care. And it seems like we have been one of the have been mostly penalized for it. We've been looking for ways to become efficient, and you guys are going to talk about that shortly. We have been looking for ways to become more efficient so that, over time, and we're one of the ones that have been more penalized for being that proactive in our self-management.
Yeah, that's well said. So speaking of efficiency, I alluded to it earlier as one of the mechanisms that CMS has considered, and there's some history to this. It dates back to at least 2018. It could date back even further, but using the efficiency factor as a means of redistributing funds that the Medicare program pays from specialty, primarily procedural-based specialties, to primary care. And the reason why I mentioned 2018 is that MedPAC, and we've had the chair of MedPAC on this show, Michael Chernow, MedPAC, the Medicare Payment Advisory Council, has advocated and spoken in their testimony to Congress since even before 2018 that there should be across-the-board cuts to procedural services, that basically the time and survey data that feeds into these services are inflated. And there's all sorts of terms that people use to discuss that inflation as it relates to the RUC. But that's really not the key issue here. This is basically CMS saying that methodology does not accurately represent what it costs to deliver these services. They are overinflated. So we're going to come up with another mechanism to do that. And that's what they're calling this efficiency adjustment. So if you look into the details.
This is what I'm going to call bullshit, because my cases have gotten a hell of a lot more complicated. And as you become more senior, you get all the stuff nobody else wants. And that's the world that I live in these days. And so, I remember it used to be like 5 minutes to do those little circles around the prostate. We ain't doing that anymore, and with all the re-radiation you do, you live in that space. You got to be very careful and not take anything for granted. So I'm going to say it one more time. Bullshit.
So let's discuss a little bit exactly what this is. So CMS is proposing a 2.5% cut, what they're calling an efficiency adjustment, to non-time-based work RVU codes. And that's the tell right there, right? Because for those who are non-proceduralists, for those who are in the clinic doing evaluation and management only and submitting the associated codes for that, those codes are exempted from this. And as I said, CMS wrote this, so this is in quotes, that this adjustment stems from CMS view that time valuations for services, procedural services in particular, are, quote, very likely overinflated, and that experience, improved workflows, and technology gains have made the delivery of these services basically faster and more efficient. And so there's a whole preamble in the text about the work RVUs and the system dating back to 1992, which Samir already discussed at length. It talks about the budget neutrality pressure and talks about all kinds of misvaluation concerns related to MACRA, et cetera, et cetera. But what this does is this affects the entire house of medicine, so not just radiation oncology, or I should say it affects the entire procedural house of medicine. So again, a 2.5 reduction to non-time-based work RVUs. This would start in 2026. And I mentioned the rationale behind it. This is CMS saying that we're going to take a corrective step moving beyond the RUC survey-based updates to reflect what CMS believes are operational improvements, and to essentially, because of cost containment pressures, is more or less what they're doing here.
I agree with Brian. I think it is bullshit. I think there's a way to redistribute toward primary care, which I think is an intent here, but it's not by robbing Peter to pay Paul. And I do agree that there is obviously concerns about overinflation in the surveys, but I will say, as someone who goes to the RUC, what they look at is not the median time responses that survey respondents get. That we never get valued based on median levels. We get valued based on the 25th percentile. 25th percentile is standard, and that's because they assume people are overinflating their times. And so we're already kind of having an efficiency factor already kind of done through the survey data. But this is something CMS has been doing for years. And Samir, I would love to hear you talk about this a little bit, because with the ROAPM, they introduced an efficiency discount factor for us, if you remember, when they were trying to create a bundled payment for us.
They did. And, boy, it's going to be, you're going to send me into PTSD talking about ROAPM. And so I think the efficiency factor, and now I'm really going back in time. For those of you who don't know, part of the provision of PAMPA was not mandating an alternative payment model, but studying a payment model. And you may remember, under the Obama White House, CMMI was created, the Center for Medicare and Medicaid Innovation. So they were very much looking at different ways to pay people. So hence how all this happened. And I think the feeling from the societies, at least from ASTRO, is we're better off designing it ourselves than having it designed for us. So it was designed. In full disclosure, I wasn't wild about what was designed initially, but then when it went off to the agency and off to the government, it really took a bad turn, to the point that really no one could support it and was withdrawing. So that's why it's not there anymore. If you're wondering at home, that's the quick history. But the efficiency factor, there was a lot of issues with the ROAPM version 1. I can't remember exactly which issue falls where, but I think one big issue was efficient practices were punished for their past good behavior. And that was something that was a little bit tough to swallow if you were at a place that was doing things correctly. Because I believe 70% of the weight was based on your own practice pattern. So if you had been doing a lot of hypofractionation during the look back period, it came out that you would be paid less than somebody in the same geographic area who had not been. And that just didn't sit well with, certainly with us in our institution, but a lot of places.
Just since we've mentioned it a few times here, I think it would be helpful for the radiation oncology listener to a reminder about what PAMPA was. So PAMPA was a law that is called PAMPA because it's an abbreviation. It means Patient Access and Medicare Protection Act. And among other things, what it did is that, and it was unanimously passed in 2015, it froze reimbursement rates for freestanding radiation oncology centers from the year it was passed through 2018. And then I think it was actually extended another year to 2019. And basically why this mattered is that freestanding facilities were facing steep reimbursement cuts, and PAMPA, basically, once it was passed, provided a buffer, allowing time to develop alternative payment strategies, which came to a head with the ROAPM, which then never came into existence. So that's what PAMPA was. And one other thing, because of Amar said something very important about the RUC and how it relates to image-guided radiation therapy and the codes for that, and the RVU that is now applied to that, because that too was up for review at the RUC this year, back in February or January, or was, of course, at the table. I was there as well. And Amar, if you could just speak about that, because there's been some heartburn already in the radiation oncology community about this RVU level.
That's a great point. So image guidance, which is both cone beam CT, ultrasound, and KV, right? Imaging. Nobody really does ultrasound anymore in our field. It's not very common for image guidance. We'll talk about that a little later. But the people who do some of this superficial radiation therapy. So, but you had cone beam CT and KV imaging. That was also the KV imaging was also a G code, and so we were also asked to fix image guidance. And when you do two things at the same time, you can't oftentimes report them separately. They want you to bundle it together. So the technical portion of image guidance is bundled into these codes for your 77402. For your 77407 and 77412. So your level 2 and your level 3 treatment delivery has the technical component of image guidance bundled in. Professionally, you can still bill separately for checking your films. The cone beam and the KV imaging codes were deleted and they were bundled together into a new code. And so the new code is not going to be the same value as a cone beam. It can never be the same value as a cone beam because it also has KV imaging, which had a lower valuation. So what they look at is they take the utilization of how much cone beam is being done in the country, how much KV imaging is being done in the country, kind of created a weighted average, which is then how you get a new kind of RVU set. So just so people understand, because everyone's going to be like, oh my God, my cone beam CT valuation has gone down. Yes, but your KV imaging has gone up because it's a bundled code. So that's kind of how that happened. And your port films now are also, those technical charges are also bundled into your treatment delivery. So you can't bill those separately anymore either.
Yeah. And that was again, nothing on the part of ACRO or on the part of ASTRO that was generated voluntarily. That is due to the mechanisms and the screens that exist in the system, like Amar explained. Doing two things together, they're going to have you review those and then come and explain what you're doing at the table, as Amar did.
So when you're talking about sitting at the table, for the different committees, the RUC, it's primarily physicians and other specialties, right?
There's physicians around the table, but they're supposed to not represent their specialties. They're appointed to this committee and they're supposed to act independent of what specialty they're from.
So that's the New York Times will take many shots at the whole CPT RUC process. Every few years, they recycle a series of articles. But
these 32 seats on the RUC, can you describe which specialties are represented and which ones are not?
Yeah. So, there's a lot of surgical specialties. Primarily, it's surgical specialties. The American College of Radiology does have a seat at the RUC. Radiation oncologists do not have a permanent seat at the RUC. It's like the Security Council for the UN. There's some countries that have a permanent seat, and then there's some that have a rotating seat. So there are some rotating seats that then people get elected to. We had Paul Wallner, who was the only radiation oncologist who sat at the RUC through a rotating seat. But otherwise, yeah, it's mainly surgical specialties.
Yeah. But those are, it is public. I just don't know it off the top of my head, but that sounds exactly right. But it is, I just wouldn't know exactly where to point the listener, but you can find the composition of who's on the RUC.
Yeah. It's on the MA website.
Yeah.
So what's the relationship between CMS and the RUC?
The RUC submits their recommendations to CMS, and CMS can choose to approve them or not. And this has now happened twice to us, as Samir brought up. In 2015, when we came with new IMRT codes and treatment delivery codes, we got them approved by the RUC. They went to CMS, and CMS was not happy with the image guidance and treatment delivery codes, and that's why they created the G codes. So they can choose to accept the RUC stuff or they cannot. This time around, they chose to accept the codes that were created, but they didn't choose to accept the valuations for practice expense and decided to do this whole new payment method of assigning them values based on hospital payments.
Yeah, this is very important. So we were facing, based on the data that the AMA generated through their so-called PPIS, which is the acronym for their survey. Radiation oncology as a field was going to face a huge cut in practice expense reimbursement due to the way that this survey was done. And our societies, ASTRO and ACRO, said, hey, hold on here. this survey is poorly done. The respondents, the intended respondents, so-called non-facility radiation oncology practices, was actually 0. And so CMS reacted saying, you guys are serving us up surveys that are not adequate, not satisfactory. And so that is in part to explain, if not totally to explain, why CMS went the APC route, which we already explained earlier in this podcast, to value that aspect of reimbursement for radiation oncology services for treatment delivery.
Yeah, I do. I think it's good. I do want to give a shout out here to our societies here. When people question the value membership, while we don't know exactly how the sausage was made on that, we certainly like the way it tastes now when it came out, because we were looking at a 40% cut on practice expense, and they held the line at 0. So when this survey came out in 2023, we at ASTRO, certainly we recognized that this was going to be problematic. And we knew it was going to be problematic because we have a relatively small number of people who can answer this. We know because of the information they ask and the way they ask it, since it's transparent, but it could violate a lot of confidentiality agreements at individual centers. So we knew it would be tough to get responses. And we knew that because we went through this, in 2009 or 2010. And so I think last year when it came out, there was some panic, but we were not panicked because, remember, a lot of people don't know this, but we started working almost immediately in parallel on an alternate survey. So out of our own expenses, I think we spent over 6 figures to contract with another firm, and we started, and we have been in the process of doing our own PPIS survey, practice expense survey, and at the same time putting significant appropriate pressure on the agency and letting them know. And I do think we don't know exactly how they ended up here, but certainly we certainly made it loud and clear that this was not a fair way to do it with a 40% cut.
Let's get back to just some of the codes. Yes. And as you brought up with the ultrasound, Brian, so let's talk a little about the surface radiation therapy changes here. And so pretty much there's now new codes to bill both surface radiation therapy, but also orthovoltage, which is important because that also applies to people who are treating benign radiation therapy. So if you're doing anything with an energy level that qualifies as surface radiation therapy, and we've now bundled in electronic brachy into that. Electronic brachy is no longer a separate code. Electronic brachy and surface radiation therapy, everything's billed with this code that's an X06 code. And then you have your orthovoltage that's billed with an X07 code. And the simulation for either of those is no longer going to be your prior simulation codes. It's now going to be this X05 code. And then if you're doing any kind of ultrasound guidance, it's going to be an X09 code. And those were also valued with the same methodology that CMS used, that they aligned it with some level of a hospital payment. They're not the highest paying things. And so it may end up curbing some of the usage of some of these treatment modalities. We shall only see as time goes on. But that's kind of how their new codes are created. It's
a fair valuation. I think it's certainly not what it was, but I think when you look at it for the equipment costs, because these systems don't cost as much, and the maintenance costs are less, and so I think it's a fair valuation of what I saw, and I think it's certainly centers that are doing a high volume are still going to be able to offer that service to patients and hopefully appropriately.
Right, and I agree, and it also allows and accounts for the real work that these people are doing. So it's the actual process of care, of simulation that people are doing for surface radiation therapy, and the ultrasound guidance that they're doing for surface radiation. So it's actually based on that description of work that they're doing. So it is a fair valuation for the procedures they're performing.
Yeah, I think that was one of the other major issues in the proposed rule that is very new and worth summarizing. And so I think you nicely did that. Gentlemen, I think we should perhaps recap what are the most important takeaways for the audience. And Amar, I think it's the new treatment codes and the APC associated issue, IGRT. We just talked about superficial, so I think we can count that as part of the summary. What else?
Let's let Brian and Samir say their bit, and then I'll tie it all together.
I think the main thing is that people understand the process, and we just gently gone over the surface here with a lot, and I appreciate your guys' time and help in trying to explain this to all the listeners. But it's more important that they become engaged in the societies, whether it's ASTRO, ACRO, or either one of them, and learn that we really do need their voice and support to kind of protect the field. And a lot of this is making sure that we protect it so that we can give good care to our patients that's high quality. And that's, our responsibility that Samir and I have as presidents of our organizations to make sure we protect the field and continue to make sure that it advances forward in improving outcomes for all our patients.
All right, Anthony, first of all, thanks for doing this. I think I would say, I think even the casual non-radiation oncology listener hopefully learned a lot, because I think hopefully this demystifies some of the process. And I think for the radiation oncology listener, hopefully you're learning that, hey, this process is complicated, and every year I feel like we're going through this. So sometimes it's good, instead of looking year to year, to step back. I think we gave some of the numbers. Our cumulative radiation oncology pool has gone down about 21% over the last 19, 20 years. The technical reimbursement in hospitals over 2015 to 2023 inclusive went down 16%. Well, for breast and prostate, but that's about 35% of the book of business, and it seems to be reflective of everything we do. In the freestanding setting, however, it's down 32%. So let me repeat that. Hospital technical down 16%. Freestanding is down 32% during that same period, because things we've covered. Fractionation is driving down reimbursement per case in both settings, whether it's a hospital or a freestanding center. But remember, in the hospital, you've heard there's hospital market basket pricing, which has been pretty generous, and roughly 45%-ish since 2010. I think I'm in the ballpark. Don't quote me on that, though. But it's in the ballpark. But on the technical side, in the freestanding centers, MRT 20 years ago in 2005 was $687 with a gypsy of 1.0. So $687. Today, it's roughly $345. So literally going down by half. So in the freestanding side, you're dealing with hypofractionation and decreased cost per fraction. And so this is why the system isn't working, especially for our members in the freestanding setting. I am terribly worried about consolidation. I think it's going to hurt access, especially in rural areas. We really need to fight to protect the private practice segment of our society, especially those that are technical. And it's really why we're big supporters of RUC, the radiation oncology case rate. We think there's something in there for everybody, but it really is. It's a really benefit and a lifeline to those who own their own equipment and practice in the freestanding setting.
So I'm very thrilled to have had you both on. And I guess my parting words would be two things. For the radiation oncologists on, please advocate on behalf of the correct changes to this rule by talking to other people who do this, whether it's through your professional societies, or if you're part of American College of Radiology, or if you go to your advocacy days with ACRO and ASCO, or ASTRO or AMA, or whatever it is. Just be involved in your professional society and try to advocate for on behalf of this. And I will give a plug for a lot of the radiation oncology listeners who may not have heard our podcast before. We delve into other topics in healthcare policy, such as Medicaid, the big beautiful bill, Medicare Advantage, prior authorization, employer-based insurance, politics, finance, you name it. So please give us a listen.
Thanks, everyone. We'll see you on the next episode of Value Health Voices podcast.